Ready? All right, everyone, we'll get started in just one more minute. Welcome, everyone, to our webinar, Can I Bill Medicaid for That? We're thrilled to have you join us today as we explore unique challenges and opportunities faced by non-traditional Medicaid providers in Ohio. I'm Brandy Davis, and I'm delighted to be here with you today as a moderator for this discussion. We'll talk about lots of things throughout the conversation. I serve as the Medicaid Policy Fellow at the Center for Community Solutions here in Cleveland, Ohio, where I direct the Center for Medicaid Policy and coordinate Medicaid policy and research work. In this webinar, we'll delve into lots of conversations about strategies and best practices that are transforming the landscape of Medicaid services. Our goal is to equip you with the knowledge and tools necessary to enhance service delivery, improve patient outcomes, and navigate the complexities of Medicaid reimbursement. We'll hear from a diverse panel of experts today who will share their insights on service delivery models, and we'll explore new and effective ways to reach and serve Medicaid beneficiaries. We'll talk about billing and reimbursement, tackling the challenges of Medicaid billing and finding solutions to maximize reimbursement. We'll have some conversations about building community engagement, those strong partnerships and trust within the communities that we serve. We'll also have policy advocacy conversations, understanding the landscape and advocating for changes that support non-traditional providers. Whether you're a seasoned provider or new to the field, this webinar is designed to provide valuable insights and practical advice that you can apply in your work. We encourage you to engage actively, ask questions, and share your experiences. Today, I'll be guiding us through our discussion, ensuring we have a dynamic and engaging conversation. Thank you for joining us. And now I want to introduce our today's panelists that we have with us today. We have with us, I'd like to introduce Lovell Custard. He's the president and CEO at Murtis Taylor Health and Human Services System, where he leads a dynamic human services organization that provides behavioral health, addiction, youth, family, residential, and senior services throughout 12 locations. At Murtis Taylor, they serve over 12,000 individuals across Cuyahoga County. We also have with us today Jenelle Hoseus. She is the Chief Policy and Partnerships Office at Health Impact Ohio and the Chief Executive Officer at the Central Ohio Pathways Hub. She has spent the last decade dedicated to public policy and healthcare advocacy. Throughout her time as an employee of the state government and nonprofits, she has worked diligently with a focus on healthcare reform and quality improvement. In addition, we have Sue Kucklick with us today. Sue Kucklick is a counselor at the May Dugan Center, a multi-service center on Cleveland's near west side. Previously, Sue served as the director of behavioral health department, one of the 6 core programs at May Dugan Center, which offers trauma-informed mental health counseling, Ryan White program services, and substance abuse services, regardless of the ability to pay. So let's go ahead and get started with our conversation. So with our panelists here today, I have a few questions for you. We'll start off just sort of introducing, if you want to just tell us about a little bit about your organization, just a couple sentences or so. We'll start off with Lovell. Can you tell us more about Murtis Taylor and go ahead and unmute yourself?
Good morning. Thank you, Brandy. As Brandy said, my name is Lovell Custard. I'm the CEO of Murtis Taylor Human Services. We've been around for more than 76 years, founded in 1948 as a settlement house, supporting immigrants and migrants settling on Cleveland's southeast side. We serve thousands every year, and our services are pretty broad. They really cross the spectrum of comprehensive outpatient community behavioral health, residential services, substance use disorder treatment, but also significant range and array of services on the human services side, such as housing, early childhood education, family preservation, youth services. Pretty much if there's a service out there, either we provide it directly, or we provide it through some type of collaborative arrangement with a partner.
Okay, thank you. And Sue, will you tell us more about the services provided?
The May Dugan Center is located on the near west side of Cleveland, where it has been for over 50 years. We have 6 core programs at the May Dugan Center. We have, of course, behavioral health, which includes trauma-informed counseling, substance abuse IOP and counseling, trauma-informed care, and a Ryan White program. We have a refugee resettlement program that serves newcomers to the community. We have the Trauma Recovery Center that serves victims of certain violent crimes, food distribution and clothing distribution program, and Seniors on the Move, which is a program that serves older adults to reduce isolation and keep them active in the community, and the Educational Resource Center, which provides GED classes, English as second language classes, and the Financial Opportunity Center and Workforce Development.
Thanks, Sue, so much. Jenelle, will you tell us a little bit about the hub?
Happy to. Thanks, Brandy. So I am employed at Health Impact Ohio, which is a regional health improvement collaborative in the Central Ohio area, although we do provide some statewide services. We are a community convener with a health equity focus. And one of the main lines of work that we support is the Central Ohio Pathways Hub. So we are contracted with the Medicaid managed care plans and other payers. We're supported by the Ohio Commission on Minority Health for our infant mortality efforts. And we contract with community care coordination agencies who could be small social service agencies up to hospital systems, who are the ones that employ community health workers who are going out into the community and working with individuals to connect them to care and service that they're in need of. We also have a statewide CHW certification program that's run by Dr. Tanika Price in our shop, really focusing on the sustainability of how we support the role of CHWs and their ability to provide care coordination within community-based settings. And our organization also does some quality improvement work throughout the state and practice coaching.
Great. Thanks for great introductions into the work that you're doing. Really great work there. So I want to know, what innovative service delivery models have you implemented to better serve Medicaid beneficiaries? Sue, how about you? We start there.
Okay. Thank you, Brandy. One of the innovative service models we use is an open intake process for all of our new clients. And this is coming into all the programs except possibly refugee resettlement, because that's a different model. Anybody can come in at any time and have an intake done, and they're going to get services here regardless of their ability to pay. They're also going to learn about all the services that we have to offer. We have no waiting list for our services. Anybody can come in for food distribution on any day that we offer it, which is Monday, Wednesday, and Friday. People can sign up for behavioral health counseling, and they're going to leave with an appointment for a diagnostic assessment. We do have a case manager who helps people get signed up for Medicaid, and even as a counselor, I can do that. And I really recommend that people be trained in how to help people apply for Medicaid. We also do community outreach at various locations, and we have a lot of community partnerships that we work with, including places like Westside Catholic Center, Joseph and Mary's Home. We work with people at Cogswell Hall, in different places like that. So having these community ties is really important.
Thanks, Sue. And do these models that you've talked about, Sue, do they address any gaps in traditional Medicaid services? How do these address the gaps?
Okay. Well, some of the gaps in Medicaid services are people who just don't know how to apply, or they don't know that they're eligible, or they're in the process of losing coverage because they don't know how to do a redetermination, and we can help with that.
Yeah, and that brings us really to our next question, like, what are the biggest challenges you face in providing non-traditional Medicaid services, just from everyone?
Well, Brandy, if I might jump in, I think
Sure.
what would be useful if we just talk just a little bit about, for the audience, what we mean by non-traditional Medicaid. I mean, that term is often used when it comes to individuals in the policy area and individuals who are working in Medicaid, but often there's a misconception or a misunderstanding or lack of clarity with respect to that. So if we start with what traditional Medicaid services include, and essentially we're talking about those services that are medically necessary, that are usually tied to a hospital stay. The individual is typically a patient, but the concept of medical necessity is central to that concept of Medicaid. And so when we move on to talk about the non-traditional Medicaid services, we're now talking about services that aren't related to necessarily being in a hospital, necessarily receiving a direct medical service. We're talking about services like home and community based services, homemaker services, housing related services, employment, peer support, and even behavioral health out in the community and in the home, schools and the rec centers and so forth, and SUD services are considered non-traditional services because the person's not in a hospital, not admitted, not being treated for a service. But what's critical when we think about traditional versus non-traditional is that concept of medical necessity, because that is essential regardless of what you're talking about, what service you're talking about as you deal with attempting to bill Medicaid. So if we think about Medicaid as this federal program that's administered by the state, when the state wants to implement a service that is not clearly a traditional Medicaid service, an inpatient type, hospital type service, that state needs to, get a state plan amendment or some type of waiver to be able to add that service in and provide that non-traditional service. So as we think about, medical necessity, as a provider organization, we have to think about, how does this tie to the person's health? How does this tie to the treatment? How does it tie to the diagnosis? Addressing the injury or disease. And when it comes to traditional Medicaid, that's usually really easy because it's a pharmaceutical, it's a procedure, it's a hospital stay, so it's real clear, and the rules and regulations are very clear, and we all know what those are. When we think about the non-traditional services, we've got to go back to the Ohio Administrative Code and really look at how it's being defined in terms of how it ties back to that traditional health outcome. So I think that's real important as we think about this. And so when Murtis Taylor provides a service, whether we are attempting to address a gap in a service area, or we're just trying to directly address a treatment service, what we do is we look back to medical necessity. We look back to, how does this connect to that illness or injury?
Right, right. That makes
Brandy,
a lot of sense because these services are along, the continuum of care. Janelle, do you want to
do you
chime
mind if I
in?
jump in? Yeah. Just to build a little bit on that idea, I think one of the other pieces to really be acknowledging here is some of the non-traditional pieces, especially in what we do with community health worker related efforts, are really focusing in on the preventative pieces.
Mm,
So when we're thinking about things like medical necessity, part of what we're trying to articulate in our data and the efforts that we're doing is tying those upstream efforts to the medical necessity of prevention, right? How do we start to articulate things that really show an impact and a return on investment for the state, but really are impacting the ability for someone to have a quality of life before we get to a point where they need a medical intervention? So when we're thinking about non-traditional spaces, it's both that preventative piece, but then also for us right now in Ohio, community health workers are not considered a provider type. And so, how do we work with the Medicaid managed care plans and other payers to really ensure that there's a level of sustainability for those individuals providing those proactive and preventative services, recognizing that as a country and a state, we have a real opportunity space to focus more on prevention rather than reactionary medical necessity.
right, right. I mean, that's definitely important. And have you had any collaborations or partnerships that have helped you achieve that? Finding that medical necessity for those home and community-based services for you to know those the services community health workers are providing.
Yeah, absolutely. Across the board, there's so many community-based organizations who are providing that type of connection to care and service. Sue mentioned helping folks sign up for Medicaid. We are constantly having supports in finding suitable housing or food security related pieces. We've done pilot programs with the Medicaid managed care plans on diabetes self-management education so that we're supporting individuals in finding sustainable resources for food security, learning more about how they can manage their diabetes in a proactive way, helping to lower their A1C. So the DSME programs have been great resources. We've been able to work with organizations across the community. And I think one of the beautiful parts about CHWs is that you have a single point of contact for the individuals being served and being worked with that's a trusted messenger, is culturally and linguistically matched with those individuals, but is a person that is in the community and knows who to go to for what resources. So I would say that the CHWs know those particular agencies and organizations who have been ready and willing to step up and support. And obviously, we couldn't do it without the Medicaid managed care plans being the active partners that they are. And we try to be collaborative with them and making sure that any of their members who would benefit from a referral to us are able to participate in those spaces.
Right. No, that's great. And so, just for the rest of our group, how do you interact? Do you interact, and how do you interact if you do with those Medicaid managed plans? Like, how do you connect with them? I know, Janelle, you talked about a pilot program. Do you have a direct relationship with the plans? What does that look like?
So we have direct contracts with each of the Medicaid managed care plans. And through those contracts, we have payment points for work that's completed within the model. But we also have referral patterns. We provide them with reports from the work that's completed. And we have ongoing and regular meetings with a majority of them because, again, we want to make sure that we're collaborating with them on any focused efforts they're having on particular HEDIS metrics, if there are ways that we can be additionally supportive in local community efforts that they're doing, all of those types of things. So we are constantly in communication with them, and it's been a benefit to the individuals that we're working with too. We're able to work with them and knowing what some of the gaps in care are for the folks that we're serving so that we're both supporting the individual that we're working with, but we're also able to support the plan in trying to make sure that those HEDIS metrics and gaps in care are addressed.
And we similarly have contracts with, all of the Medicaid managed care organizations. Some of those contracts are, they appear to read very similar to Medicaid because of, many of the Medicaid services, are, set up through established requirements to those MCOs. But paralleling, a service that we offer similar to parallel to community health workers would be peer support, and you were asking about collaboration. So we've delivered peer support for many years, and on the mental health side, as well as on the SUD side, substance use disorder treatment side. With respect to substance use disorder treatment, the Ohio Administrative Code and Medicaid has paid for that service, has a billing code and allows you to bill for that service for many years. But just recently has, on the mental health side, when you're looking at peer supporters who provide mental health services, did that new administrative code go live and that ability to bill happen. And we saw more of a demand for mental health peer supporters than SUD peer supporters in our line of business. And so we actually worked with Cuyahoga County's Adams Board in order to, from a collaborative perspective, in order to cover the costs as well as using general operating funds to deliver those services for many years before Medicaid actually picked them up. So Medicaid just picked them up this September, and they're now billable services through Medicaid. But we were sort of ready, if you will, ready to be certified as an institution. And that's important when we talk about Medicaid services. There's usually some type of certification and licensure for the organization. And then there are going to be provider requirements for those individuals who actually deliver the services. So in this particular case, because of our collaborative partnership, we delivered them outside of Medicaid because Medicaid wasn't yet a non-traditional Medicaid service. And then once it became, come this September, a traditional Medicaid service, we were in a position to begin that process. And then there's often usually some requirement, depending on the nature of what you do, to have some type of national accreditation for the service. So there's usually, certification at the organization level, certification at the provider level. And then I'm not familiar with every non-traditional service, so there may be some exceptions, but in most cases, there's some type of accreditation required.
Thank you. And Sue, can you tell us a little bit more about what that looks like at your organization?
Okay. Well, what we have is relationships with all the different Medicaid providers. They will come on site with their van and provide services when we have, say, a food distribution day, and they'll share their services and even do exams, maybe have exams on site, link people with other services. And that's pretty innovative that people can walk up and actually learn about these different offerings that the Medicaid programs have, because they're all different. And not everybody knows this, that maybe one plan has more transportation than the other. Another one may actually have some housing assistance. Another one may offer some cash benefit for reaching health milestones. And once again, these non-traditional services are things like behavioral health counseling, substance abuse treatment, case management services that provide community-based services for mental health and substance abuse people that are not tied to clinics or hospitals, or say a federally qualified health clinic, or your health clinic that you go to see your PCP. We're a freestanding behavioral health program. We're not a community mental health center, which is another model of service provision that has a different funding model.
Great, thank you. So we have I want to go to the chat for a second. Does anyone have peer navigators?
We do not.
Okay, you do not?
We don't have peer navigators that we bill for as a hub. Several of the individuals who serve as community health workers within our hub are able to provide peer navigation services as well through a separate portion of the work that they do. But we do find that some of the most the CHWs in our program who have the highest rate of success with the individuals that they're working with often have similar lived experiences, which is why a peer navigation parallel feels like it makes the most sense with a CHW role.
For those that do have that sort of parallel relationship and those CHWs, are they billing for their CHW service and just happen to be a navigator, or is there funding available for those peer navigator services?
It's a wholly separate effort. So from a very high level, we kind of explained that the CHWs are there to provide the connection to the care and service. They are not to provide a care and service. They're educating the clients, they're providing resources, but they are not providing an ongoing effort like a peer navigation type related service. So those would have to be billed through the CHW/peer navigators organization through an actual provider related effort versus ours, which is contractually based.
Sure, thank you for that. So we've talked a little bit about medical necessity and sort of answering that medical necessity question. So how do you measure the impact of services on the patient outcomes at your organizations?
Well, go ahead.
Go right ahead, Sue.
I was going to say that starts at the diagnostic assessment. The diagnostic assessment provides your diagnosis and a set of problems to be addressed. And from there, what you do is you establish a baseline outcome measure, which are evidence-based measures that tell you what a treatment model is going to look like, so that you can pick the right evidence-based model of care. And then what you do is ongoing, you do outcome measures that are evidence-based. These will be things like the brief addiction monitor for people who are in substance abuse treatment, the PHQ-9, which is a depression screening, the GAD-7, which is a anxiety screening, and the PCL-5, which is for PTSD, which I know that a lot of us see a lot of trauma-related disorders in our practices. And with these outcome measures, you can show both to payers and your client the progress that they're making on an ongoing basis. And most medical record programs, EHRs, are going to have graphs for you to present so that you can show your client, hey, 90 days ago, this is what it looked like when you came in. Now we're going to look at your treatment planning, which is another very important part of this, because your medical necessity is followed in that treatment planning process. There are guidelines at the state level and the Medicaid level that tell us what we have to do regarding treatment planning and reviewing treatment plans. So what we do through that is we track progress, change goals. And the thing is that if you get audited, they're going to look at that treatment plan, that diagnosis, and those case notes to see what you were doing. I get these reviews all the time, requests for reviews, and I have to send entire charts to payers. And they're tracking what's going on with that client. Are they especially if they're getting intensive services like an intensive outpatient program of any kind or a partial hospitalization program that pay at these high rates, they want to know, how are we measuring progress? What progress is this level of care justified? Because they want to know, what are we paying for?
And if I might jump in, as Sue is describing, for the audience that's interested in, beginning the process of delivering or incorporating a non-traditional Medicaid service, or even pretty much a non-traditional Medicaid service, unless they're a hospital, into their organization. It's going to start with, as Sue mentioned, you're going to start the service with the outcome in mind. And, you will find, depending on the service, so as we talk about non-traditional services, supportive employment, transportation, peer support, behavioral health, and so on. Some of these are obviously very clinical. And so you're talking treatment plans, and we're talking about transportation. I would imagine that the outcomes are going to look more like outputs, in the number of rides, what's been the change in the person's compliance with respect to their appointments and so forth. So you're going to start with that outcome in mind, and you're going to identify a set of instruments that make the most sense. And, we use Ohio scales, we use NOMS, national outcome measures, depending on what we're actually delivering. And in some cases, we actually create our own instruments that are tied specifically to the service, because there isn't anything out there that really gets to the outcomes that we're focused on. And then you integrate that throughout the organization, whereas you typically are going to have somebody responsible, or even a department that you're going to call quality improvement, quality assurance, but it doesn't sit with that one person or that department. It really has to sit with that first person who's doing that initial, assessment, that person who's delivering the services. And you really want to take that information, as Sue mentioned, where you're showing it to the client. You really want to take that information and incorporate it into the visits with the client. So, we're talking about peer support. You're, looking, at the data with the client, and you're modifying the services that you're delivering based on what you're seeing in terms of the person's improvement. And I would imagine transportation or peer support or recovery, specialized recovery services would look very similar, but tied to whatever the outcomes of that particular service. So really, if you're getting into, the business of delivering going into the business of delivering a non-traditional Medicaid service, start with the person in mind and start with what you're trying to do in terms of impacting that improvement.
So if I can just add a little bit too.
Sure.
So in the CHW Pathways Hub model, the initial interaction with the individual is a comprehensive risk assessment, right? So we are getting a very thorough understanding of all of the different needs and risks that are going on in the individual's life. And so that is a helpful place for us to start and better understanding goal states, all of those things. On top of that, we have several ways in which we've been able to articulate the outcomes and the return on investment. The plans, the Medicaid managed care plans, several of them have actually done ROI studies, CareSource being the latest one to work with us on some ROI understandings. And on top of that, we also are able to see it in our data. So as Ohio Commission on Minority Health grant recipients in 2023, we had a 96% healthy birth weight rate amongst the babies that were born to us within that cohort. Obviously, because it's through the Commission on Minority Health, we have to have at least 80% of those individuals participating be a racial minority, which is even more important given the disparities that we see in the infant mortality crisis going on in the state. So there are points like that where we're able to look at our data versus the same data for Franklin County overall and know that the impact that our CHWs are having is really critical. So I would just say that our data is able to really speak for itself when it comes to the level of impact that is being seen. In addition to that, we have a 76% success rate on any of our goals being accomplished with the clients that we're participating with. And that's including things like one of the goals is a housing pathway, which requires that the person not only get housed, but they stay there for at least 30 days or more. So it is a truly closed loop referral system, and our CHWs are getting to the point where we're able to support them in finding that resource, but also maintaining it, which is really critical within our data as well.
Yeah, I think Jenelle and Sue make an important point. So we're looking at using outcomes at the client level, but also at the program and institutional level. So you're looking at this data, and if you're at a 79% for the program or for a particular service, that gives you, a marker to figure out how do you improve. Are you going in the right direction? But at the same time, when you're looking at an individual's data and you're explaining to them, how well they're doing, and you're actually modifying the treatment plan or treatment delivery, you're having, this micro impact that's impacting the program and the institutional level. So it's all integrated, and you really, whether it's a Medicaid, traditional, non-traditional, or any service, data is extremely important, and you have to start person-centered at the start, and think about what outcomes you want to achieve, and start collecting that baseline and that interval data to figure out if you're moving in the right direction. It's just not about the number of services. It's about changes in the person's health.
Absolutely.
Yeah, because we're looking at more than just changes in personal health. We're looking at community outcomes. We have to look at the entire community, access to care, health disparities, social determinants of health, and look at this and say, okay, as a trauma responsive community of care, what are we doing? You know, how do we talk to each other about this?
But it's also why it's even more important for non-traditional providers to find some form of funding that's sustainable, right? Because there are portions of the work that non-traditional providers are providing that are going to meet needs that will actually move the needle that on the areas where we've been unable to do so thus far. So I think it emphasizes the need for the concrete data that we've all been talking about to be acknowledged through sustainable funding mechanisms. And I do want to give a little bit of a shout out to HPIO in particular for doing some significant work with health-related social needs. I know the Center for Community Solutions has been sitting at the table for all of those conversations too. But I think the more we can rally as community partners and as providers in these types of spaces where we talk about the data showing the impact that we're having on those individuals and on that community, it's going to help to emphasize the importance of unique community-based solutions that are going to support individuals who haven't traditionally been able to be supported in the way they needed.
And I think it's important that those listening, you know, the small institutions that are figuring out how do I, you know, create a non-traditional Medicaid stream, how do I incorporate one of these services into my organization, to not hear, you know, what we're describing as we talk about outcomes is, I mean, it can sound very intimidating because we're talking about collecting a lot of data, analyzing this data, and a person may say, I have no idea what that's about or how to do it. Start with identifying what you're trying to achieve. What's the purpose of the service? What is the medical necessity? That's where it's going to begin. I mean, if you're looking at a transportation program and the goal is to, you know, help address individuals, you know, going to the physician's office on a regular basis, you know, start looking at what do you need to collect, you know, identifying what's out there, do the, you know, website research but don't let, you know, the concept of, you know, ROI and statistical reports or statistical requirements stop you from starting. You really need to move forward, identifying just on the basic level, what are you trying to achieve? And then you can get sophisticated as you move forward. And as you look at the Ohio Administrative Code and you begin looking at, you know, becoming certified and so forth, that's going to spell out what you need to do. I mean, they're going to talk about specifically, you know, what needs to be tracked. And once you start to get involved with MCOs, they're going to have some requirements as well. And so, you know, it'll start to define itself for you as you move forward.
Right. And so with consideration for getting involved with MCOs, have you had Medicaid or any Medicaid managed care organization come in and do any trainings, or have you done any trainings with them, sort of get up to speed, or how do you access information from Medicaid to sort of guide your work that you're doing and make sure that you're doing things accurately?
Well, I would give a shout out to CareSource, who has an ongoing behavioral health meeting to open themselves to providers for any kind of questions that we might have. And that's very helpful. Also, Ohio Job and Family Services has had some webinars as well where we could ask questions and talk about things like how long you have to wait on the telephone to try to access somebody to do a redetermination. I even got an email address that was helpful and got problems resolved from the top. So that was helpful. But anytime they do a community education, that's so helpful.
For sure.
Yeah.
Yeah, I
So,
think it differs amongst the 8 MCOs. Some, CareSource being the largest, and in terms of, what, how they, outreach and services they provide. Most have some form of office hours, some form of a webinar that you can connect with. Just like any other industry, you're going to find a situation where there's going to be more attention given to the larger institutions that, bring more business and have more clients. The MCOs are businesses, even though some, identify themselves as nonprofits, and they are trying to make a profit, on care. And so, it is going to be, it's going to differ depending on the MCO that you're actually working with. And, once you become certified, once you, as an institution, are in a position to deliver these services, it's just a matter of picking up the phone and contacting or Googling them and contacting the institutions to establish the agreement. They're very eager to expand their networks. So if you provide the service and you want to be in their network, they will definitely respond to that.
And they do have community outreach people who are very helpful in establishing those kind of relationships.
Thanks for that. That's great information. Speaking about establishing relationships and things, how do we prepare to adapt to some of the changes that are coming up with Medicaid? Are there things that you've done to sort of prepare for potential changes and trends and billing for the future of non-traditional Medicaid providers and services? Like what does that look like for you, your organization? What are you hearing or doing?
So our contracts with the Medicaid managed care plans are based on their administrative portion of their capitation rate. So we are not a medical provider. They do not get reimbursement from Medicaid that is specific to medical work for our contracts, right? So the pot of funds that are available for administrative purposes for the plans are also the same pot of funds that are used for community reinvestment and some of the other reimbursement methodologies for some of the language that was required of them in the next generation contracts from the Department of Medicaid. So really focusing on care coordination, community-based efforts, things in that space. So as hubs, we're really fortunate because there is Ohio revised code that specifies that the plans contract with us. There isn't a lot of detail there. And so recognizing that the plans do have a lot of obligations, we're really trying, and quite frankly, because it's the right thing to do, we're trying to work with them and amongst ourselves to think about innovative payment methodologies and what that could look like so that we can continue to support this work and continue to stay sustainable, recognizing that the need for the folks the need for CHWs to work with folks is only growing. The individuals that we are working with are really interested in maintaining those relationships with the CHWs. We want to make sure that a community health worker, whether they are in a hub, whether they are in a community-based setting, in a hospital setting, regardless of where they are, that they are supported to be able to do their job and their passion and to continue to serve the community. So we're just trying to work with the plans to really be innovative about how we can continue to support in those spaces, especially financially. I know that there was a question in the chat around 1115 waivers. That is a massive undertaking for the Department of Medicaid to take on. So we're here for the conversation. I would love to talk about an 1115. I know that the Department of Medicaid is examining one from a reentry and incarceration perspective right now. We would love to be able to talk about one from the health-related social needs space if the department was ever up for that conversation. And so those waivers in particular require the department to go to CMS at the federal level and ask for basically permission to do something that is specifically not outlined as an appropriate service in Section 1115 of the Social Security Act. So it could be geographically specific rather than statewide. It could be a population that normally doesn't have access to Medicaid services. like individuals who are in an institution like incarceration. It could be a whole bunch of different things. And we would love to work with the department on something like that, but we also recognize that that is a lift on their end rather than something that we can do administratively through our contracts with the Medicaid managed care plan. So we're just trying to be innovative, continue to showcase the value proposition of the work that we do, showcase it in the data, showcase it in the relationships, and continue to put our best foot forward in the collaborative spirit that we've been trying to bring this through this work.
That collaboration is so important, so important. And so for those of you who do bill Medicaid, obviously, we've really talked about a complex process here. So what are some of the biggest, most common challenges you face as a non-traditional Medicaid provider?
I think probably the biggest challenge is the low reimbursement rates. They were increased 20%, but the last time they increased the rates was 20 years ago. The cost of doing business these days is much higher. You are not able to hire people directly out of college with no credentials anymore to do this work. We are hiring master's level clinicians to do this kind of work in the behavioral health space now.
I think the rates, are a challenge. I mean, we just received a 12% rate just recently at the start of 24, which has made which was, as Sue mentioned, it's the first time we've got a rate since I believe it was 1999. I think some believe that in 2018, when Medicaid redesign occurred, that represented a rate increase. I think if you really look at that data, it didn't, because of how the different services, at least on the behavioral health side, how the different services went up and down. So pharmacological management versus case management, I think it washed itself out. So really, the 12% that we received in 2024 was really the first time we've had a rate in 20 years based on our data, a rate increase in 20 years based on our data. But just as important as the rate is the timely payment. So in 2018, we moved to redesign, a behavioral health redesign, and this is talking about non-traditional services with respect to behavioral health SUD services, and at the time SUD peer support, and now mental health peer support. So when in 2018, when that redesign occurred, essentially instead of the Office of Medicaid paying directly providers of these services, those payments now come through the managed care organizations. And each managed care organization adjudicates claims differently. It has its own formulas, its own business practices. Even though they have a standard Medicaid contract and they're supposed to do things a certain way, they don't necessarily do things a certain way. So one of the things we will find is we'll have a provider who works for us, who delivers 100 services in a month to clients, some of which are at one MCO and some of which are at two other MCOs. And two other MCOs will pay all of the services, and the one MCO, exact same claims, will reject those claims. Or one MCO will get paid within, I don't think anybody pays better than 30 days, but we'll get paid within 30, and another one will get paid in 90. I know there are rules around how quickly they have to adjudicate and pay the claims, but those rules really only say how quickly they have to respond to you. A response of rejection, denial, or we have questions effectively is a response. And so as long as you get some response within, I believe, the 30-day window, that claim still can go on for 90 days and never get paid. And so your receivables are really, a challenge. And if you think about it as an institution, regardless of size, you have to pay your employees. And in order to pay your employees, you need the MCOs to pay you. Employees, I can't say to my employees, oh, I'm going to pay you in 90 days. They want to be paid every week, like clockwork. However, the MCOs don't necessarily pay you every week at clockwork because of the varying practices within the 8 MCOs that operate Medicaid. And then some services, based on whether the person is in sort of a limbo with respect to having chosen a plan, will come directly out of Medicaid itself. So, some services are billed to the Office of Medicaid, and they bill the best and the fastest. So it's interesting. There's always that, accusation that the private sector does things better than government. But not when it comes to timely payment of Medicaid. The Office of Medicaid is a much more timely and effective payer. So that you could see that as a complaint over redesign. I've been complaining since 2018.
Yeah.
Go ahead, Sue.
Yeah, the other question we had was credentialing. We had 2 people in our organization that it took close to a year for us to get credentialed under the redesign, which meant our claims weren't getting paid.
Which is not, and speaking for that, these small institutions that are thinking about getting into the business, understand it's not like you bill a claim and that claim is going to get paid tomorrow. There's an adjudication process. They're, making sure the claim is legitimate, making sure that they're the right payer for the claim. And there are all kinds of challenges when it comes to, timeliness of these claims, and behavioral health. We're very fortunate across Ohio that they have the Adams boards, which provide in the various counties, which provide, payment for services for those who aren't on Medicaid. It may be that, they've fallen off Medicaid, a variety of reasons. Well, typically Adams boards will pay within, we'll let you go back to 90 days. Well, if an MCO has taken 180 days to adjudicate a claim or constantly going back and forth, it's too late to now, and they determine it's not them that you should be paying. It's too late to go to your local Adams board and get that indigent care payment, simply because the time period has run out. So that becomes a challenge, and the national correct coding is also a challenge when it comes to making sure that the types of services that are being delivered, how you bundle those services, and the days that you deliver the services. In our business, Sue can attest, if you have that diagnostic assessment or that PDE on the same day that there's an injection, or that E&M service on the same date that there's an injection, you're going to get paid for one and not the other. And in many cases, somebody who shows up and they need to see a psychiatrist for that outpatient service, also, psychiatrist saying to the nurse, give this person a shot now. This person needs their long-acting injectable today. And so it's not like you can send them away with a bus ticket and ask them to come back tomorrow. So you can get paid for both of those services, because national correct coding doesn't allow for those 2 services to be paid for on the same day. Services are needed on the same day the doctor says they need them, but you can't get paid for them on the same day. So there's a variety of rules and regulations when it comes to, how you bill, how you code for those services that will take time. Small organizations, it may be a little easier because you're not looking at the volume, but once you get to a certain point of volume, you're going to need software to do that work, and to bill those services. And the challenge actually increases with volume, the complexity.
All right. And
Sure.
the other thing is the behavioral health did not get financial assistance from the federal government to transition to electronic health records.
Right, right. That is tough. That is really tough. And we talked about billing sort of being an issue with sort of but how do you maximize the reimbursement that you do have for these non-traditional services? Because obviously you're still around as an organization. So how do you do that to maximize those services,
Well,
Randy, can I
go ahead.
Can I jump in really quickly on the last
Sure.
point? I just want to say something really quickly on that. So one, we're really lucky because we're written into administrate or revised code to be able to build the plans as an administrative thing, but also there's nothing to necessarily like help facilitate some of the contractual obligations or conversations. So there is no floor for our payment methodology. We don't have rate structures. It's all just agreed upon between us and the plans. So take that for what it is. And then the other piece I wanted to make sure I said out loud is part of what it makes it difficult is we are in the business of preventative care.
Mm-hmm.
We try to do ROI studies, we try to articulate it in outcomes, but we're creating never events. We're making it so the person doesn't show up in the ED. We're making it so that the baby is born full term. We're doing the things to support individuals so that they have a better quality of life and health outcomes that perhaps they wouldn't have had access to or the ability to have accomplished without the CHW walking alongside them. And I think that our healthcare system and our payer structures are much more inclined to reimburse for things on the back end rather than the front end. And so helping to continue to readjust the lens to have it be something where we get paid more or I don't want to say adequately, or get paid period for preventative work is something that is, I think, still something that needs to be continued to be worked on. Sorry.
Right. No, sure. That's definitely an opportunity.
That's very helpful. Yes.
We love to talk about opportunities here. But, so how, again, like how do you maximize, the reimbursements that you do get? I know, Jenelle, this is a little bit different for you, but just like Sue, especially Sue and Lovell, how do you maximize that just across your organizations? Because you're doing a great work, both of you are.
I'll let you go, Sue, first.
One thing I was going to bring up is the idea of outcome-based care, which ties right into what Ms. Hoseus was talking about. This is a model we're starting to see in behavioral health care where we would get paid higher rates for good outcomes. And, that would maximize our efforts a little bit. So I'll let you take that on.
So yeah. Outcome-based care is something that we're moving into, but right now we're really in a fee-for-service environment for the most part. 90+% of what services that are actually provided. Brandy, we stay away from words like maximize because it implies that we are delivering the services or manipulating how we deliver the services so that we get the maximum rate. So, we really focus on being person-centered, identifying what the needs of that person are, try to be as efficient as we can with the delivery of those services, and meet the client where they are. So, here's a way we achieve that. So we may use technology, and we have multiple sites across Cuyahoga County, and so a client may show up to see a case manager in one facility, and we don't have a therapist or a physician at that facility. And so they may be at another facility. Well, we have what we call telehealth rooms where the person can actually go into the room, sit in front of, and we can connect that person to a psychiatrist at another facility. The case manager will end their service, and then someone will assist them with receiving that same service while we still have the client, connected. So we try to be as efficient as we can, but I guess and I can see the time sort of going away, but sort of as concluding remarks, I think it's real important to understand that it's real important to understand the legal aspects of Medicaid. And you can really find yourself in a pickle if you don't understand the legal requirements of Medicaid. It's not the Wild Wild West. You must ensure that you're compliant, and also, and I'm not sure how this is looked at in terms of size organizations, but you have to also think about antitrust. As Jenelle mentioned, we collaborate a lot, but her contracts are negotiated with her and the various MCOs. It would be inappropriate for her to then get with another partner and have a conversation so that she maximized the rate, because now she's price fixing. And I know I'm getting into areas, but in my business, I'm always dealing with risk. And so it's real important. You must understand the legal aspects of Medicaid and fraud statutes, as well as antitrust statutes as you move into this area. Everybody must, within the organization, from the person delivering the service to the person over the organization, because the institution can be civilly liable and individuals can be criminally liable, whether you delivered the service or not.
The only thing I would add to that is continuing to showcase value proposition. The plans have been remarkable partners when it comes to being willing to innovate, especially if it's on populations that perhaps they acknowledge the expertise of RCHWs are going to play a critical role in being able to reach that person both physically and emotionally where they are. And also thinking about things like bundled payments or other innovative payment methodologies where we're able to say, okay, if we're able to accomplish X, Y, and Z, then that's an additional value proposition. Or if we're able to impact this particular HEDIS metric, that's a benefit to you all. So really thinking about what is the mutually beneficial opportunity spaces and trying to talk about if there are contractual opportunities for everybody to be on the receiving end of a winning situation, especially the client we're serving.
Yeah. Yeah. This has been a great conversation. I wish we could talk so much longer. Thank you all. A big thank you to our panelists here today. We hope that you've gotten something and taking something away. This recording will be sent out to everyone. And I hope that you have a great weekend. Please check out communitysolutions.com for more information. We will continue to provide updates and following this topic. So take care, everyone.
Thanks.
Bye-bye.